So thank you so much. This is the last session. So it is just a quick recap of what we have discussed today. So all of you know that the PPH is the fastest killer, and we all have assembled here to learn the skill to win PPH. मैंने morning में भी बताया था कि I wore red, मैंने लाल पहना, इस लाल को मैंने इसलिए पहना कि मैं इससे डरती नहीं हूँ, मैं इसको जीत के जाऊँगी. So save mothers and stop PPH. So the FIGO says that the postpartum hemorrhage is a heavy blood loss after babies is born, that is more than 500 or 1000 ml, and every day approximately 130 women die from complications of pregnancy and childbirth, and PPH is the leading cause. The majority of these deaths are preventable. So we are talking about the preventable and treatable part. Yeah. So when you look at this picture, you just see that amongst the causes of maternal mortality in India, approximately 38% are because of postpartum hemorrhage. And in different parts of India, they vary from 35 to 56%. In areas like Madhya Pradesh, Uttar Pradesh, Odisha, Assam, the maternal mortality is very high because of postpartum hemorrhage. So let's get started. So now over to Dr. Shiba.
Yes, thank you, ma'am. So it's a great opportunity to be amongst the stalwarts, ending this great workshop with a panel discussion. So PPH, as we all know, it's a quick recap. So it's a blood loss of more than 1000 ml regardless of route of delivery. There are various classifications, but it's mainly classified into minor and major PPH. And actually, the blood loss more than 40% of the total blood volume of the patient, that is regarded as life-threatening. And blood volume at term is 100 ml per kg. An average Indian woman weighing 60 kg can tolerate that much blood loss, but a 2400 ml blood loss, that is 60% of the total blood volume, would be life-threatening to her. And ma'am has already said that women die from postpartum hemorrhage because they do not receive early, effective and aggressively life-saving treatments. And it is the biggest and fastest killer. And there are many delays, and time is very important. So we have to manage, time is precious, and people.
So these are very important words of wisdom by Sir Ian Donald. While managing postpartum hemorrhage, the time lapsed should not be counted in 1 minute. One has not lost 1 minute but 60 seconds. So the most important thing is time.
Yes, ma'am. So time is very precious, and now the studies have really highlighted the importance of golden hour even in PPH. So the first 60 minutes from the time of recognition of PPH, in which resuscitation must begin to achieve maximum survival, is the golden hour. And as more time elapses between the point of severe shock and the start of resuscitative efforts, the percentage of surviving patient really decreases. So time is very important.
Most important. Time.
And we should not waste time in assessing blood loss because visual assessment is often inadequate, and we have lots of aids these days which would add up to the estimation of blood loss. And this rule of 30 is very important. When the systolic blood pressure falls by 30 millimeters of mercury, the heart rate raises by 30 beats per minute, respiratory rate goes to 30 breaths per minute, hematocrit drops by 30%, urine output is less than 30 ml per hour. So this means that the blood loss has already occurred of 30% of the normal, and we must now make all the efforts to save this patient. So this was all the background of the grading of blood loss, and with this background we start with our first case to stump all the stalwarts sitting on the panel dais. So the case was the 36-year-old G5P4L4 at 38 weeks of pregnancy. She was a case of GDM and anemia in this pregnancy on insulin. She was induced in view of 38 completed weeks with GDM on insulin, and she delivered a 3.8 kg male baby. Active management of third stage of labor was done. Patient suddenly started bleeding profusely after the removal of placenta, which was complete on examination. Her pulse was still 80 per minute, blood pressure was 110 per 80 millimeters of mercury, and estimated blood loss was 800 ml. So my first question goes to Dr. Taru ma'am. Ma'am, what do you think the cause could be, and how would you manage the case?
See, in your case, it seems to be most probably atonic PPH because there are multiple risk factors for uterine atonicity. Like she was elderly, she was multigravida, gravida 5, para 3. She was already anemic, then she was induced. Then further she gave birth to a good sized baby, 3.8 kg. So most probably it seems to be uterine atonicity responsible for PPH. So in such patients, antenatally it is our duty that the hemoglobin should be built up when we know that we should recognize these patients that she is a high risk for PPH or third stage complications. So the hemoglobin should be built up well, and before delivery, the blood should be availability and cross match should be done. Because she
so
is
the first step in the management and treatment of postpartum hemorrhage is to build up hemoglobin.
Yes, ma'am. Even RCOG endorses the same. And as you have clearly highlighted, she had all the risk factors for atonic PPH.
Very nicely elaborated, Dr. Taru.
And you said that she had lost roughly around 800 ml. The visual estimation is always underestimation. So she must have lost more. So we should start management. We should start uterotonics. Oxytocin 20 units should be given in drip.
We'll go to that.
Catheterization should be. Shall I stop or shall I continue?
Yes, you can.
So the next question goes to Dr. Anita ma'am. Ma'am, what type of PPH is this, as already ma'am has said, and how would you manage?
Yes, the management would definitely start as highlighted by Taru. Antenatal, antenatal good assessment is very important. You should treat anemia and all these things. And preparedness is the key. Once you are delivering a diabetic who is already anemic, you should have enough blood arranged for her while you are conducting the delivery for her. And the diagnosis made by Taru is atonic PPH. So definitely the whole PPH drill we are always encountering has to be there. Ask for help. Ask for help. Don't shout for help. The word has been changed from shout to call for help. So because if you will shout, then the whole panic reaction starts. Try to gather as much as team members as possible. Start whiteboard, IV cannulas. And then your ABCD procedure will start, grouping, cross-matching, sending blood for investigations, coagulation profile, arranging for
Please elaborate on medical treatment which you can give.
So, and meanwhile you start with the, immediately you start with the uterine massage, rule out any retained products of conception, give good oxytocics, whatever you have, like oxytocin drip or, carbitocin is not given as treatment. If it would have been given, it would have been given for prophylaxis. And if you do not have oxytocin with this is not a possibility with current era, but even if you have argometrin, or you have prostaglandin injection available, you start giving the patient.
Thank you, Dr. Anita. So here there are two important points to be taken home. First thing is this, that the oxytocin is the drug of choice for active management of third stage of labor. And again, oxytocin is a drug of choice for initial uterotonic management of postpartum hemorrhage. As per latest FIGO guideline also, RCOG, WHO, everything. And the second thing is that, remember two words, carbetocin, C for carbetocin and C for carboprost. Carbetocin is only meant for prophylaxis of postpartum hemorrhage, and carbetocin is meant only for prophylaxis, not for treatment, and carboprost is only for treatment, not for prophylaxis. Next.
Yes, ma'am. So in this patient going ahead, she had no response, blood loss continued, pallor increased, uterus was still flabby, her pulse went up to 86 per minute, blood pressure went down to 102/70, and blood loss was now approximately 1000 ml. So as uterotonics were already told by ma'am, so we move up the protocol and go ahead with other uterotonics, and we must consider tranexamic acid as well. So my next question goes to Dr. Reena ma'am. Ma'am, is there any role of using tranexamic acid?
Dr. Reena.
Taru ma'am.
Reena ma'am.
So WHO advocates injection tranexamic acid in all sorts of PPH, whether it is atonic or traumatic. The important message is that it should be given as early as possible, within 3 hours of birth, and it should be given 1 gram, that is 1 gram in 10 ml normal saline. It will contain 100 milligrams per ml, so that it should be given over 10 minutes. So the tranexamic acid is a wonderful drug, and it acts in both atonic and traumatic PPH.
So the important take-home message is tranexamic acid is an additional thing besides uterotonics, and it has its independent effect, and it should be given as soon as PPH happens, and it decreases maternal mortality by 30%, and in traumatic PPH is work wonders. Yes, in all PPH, as per FIGO guideline, all PPH. So yes, ma'am.
All PPH except those which are
not
having...
only for treatment.
So, except that those which are having any thromboembolic events. See,
Yeah.
those patients it is
Contraindication has to be
contraindicated.
given. Yeah, right.
Rest of them it should be given. And in fact, if within 30 minutes the bleeding is not stopped, you can even repeat the dose.
the dose.
Yes,
So, 2
yes.
doses can be
Yeah.
comfortably given.
Yeah.
Routinely
it has to be
It will not have any
initiated
effect
within
after 24 hours, and it is only for treatment, it is not for prophylaxis.
But in patients,
We should not have
Dr.
given
Shashi,
it.
in patients with pars placenta accreta spectrum, in those patients, the guidelines say that we can give at
Okay.
the start, after cord
Okay.
clamping, we can give injection
Yes, that
as
we
a
can do.
prophylaxis only. Otherwise, it is a therapeutic.
Yeah.
So it also says that there is some potential for harm if you give it after 3 hours.
In cases of placenta previa also where you are anticipating that bleeding is going to be there for
Yes, ma'am.
Ma'am, we can give that
Yes, ma'am.
after cord cutting.
the baby, it is given.
So these are the high risk patients who are for high risk for PPH. So in, yes, ma'am.
Now many people outside and as well as people are doing it tranexamic acid prophylactically on all elective cesarean.
But the guidelines do not favor this.
Guidelines do not.
Guidelines don't say.
They've started using it.
No, ma'am.
Ma'am, we are already having a thesis on this, giving prophylactically at the time of cesarean. Just.
Getting the trial is already there and they find there is a good use of it.
Can I add?
Ma'am, we are
concerned that pregnancy and percurium is a pro-coagulable state. So tranexamic acid has to be given with caution, as Renu ma'am has highlighted. One must do very judicious use if you are giving it prophylactically.
Next picture.
5 years.
ये अच्छा क्वेश्चन है.
I think it's a wonderful
हाँ, ये डॉक्टर रीना यादव मैम से.
ma'am, we,
ठीक हो रहा है. नहीं है.
so Vanda ma'am is not here, but Reena ma'am is our expert. So ma'am, we would like to you to take this question. Ma'am, would you like to give misoprostol if the patient has already received prophylactic misoprostol?
Yes, ma'am. There is no rule. Rightly
Yes,
said,
correct,
ma'am.
ma'am. We wanted to emphasize this point for our postgraduates and our budding gynecologists because the FIGO 22 clearly states that there is no evidence about the safety and efficacy of an additional 800 microgram dose of misoprostol for treatment of PPH when given to women who have already received 600 microgram of prophylactic misoprostol.
So this is a very important point, especially for postgraduates also.
Yes, ma'am. So going in with the case, she did not have any response with this medical management. Her pallor kept on increasing, her pulse went on shooting, her blood pressure kept on falling, and her blood loss was still, though, approximately 1000 ml. So what next we should do? Dr. Punita ma'am, if you want to take this question, how to proceed further?
Yeah, thank you. So this patient is already medical management was on, but we do not have to wait till the last dose of giving medical treatment. This is very critical decision when to augment the next step. So in this case, in addition to whatever medical management is going on, we will have to arrange for resuscitation and for arranging blood. Then we have to also start the temporizing measures like uterine massage. We will continue, and here is the role of if the expert, and it is to be given judicially, we can give external aortic compression, and then we have to start the first step of giving, if it is a atonic PPH, we can start the uterine balloon tamponade. So we have already discussed in the previous sessions various availability, but we have to be very sure that it has to be a atonic PPH. The traumatic part has been already ruled out. Any retained membranes or placenta has been ruled out. And secondly, this also acts as a tamponade test. Like when we have put the when we have put this uterine balloon tamponade and we find that the bleeding is decreasing, that means it's going to be successful. But if we realize that in spite of the atonic, in spite of this balloon tamponade, the bleeding is continuing, then is the time that we should quickly take a decision that patient may need a laparotomy.
Yeah. So ma'am, there should be an early recourse to surgical procedures. Yes,
Let
ma'am.
us move.
Yeah, madam has highlighted that there may not be any revealed bleeding.
Yes, ma'am.
So it is not a problem with other balloons, but our homemade, we are having, we are making our own
Condom
because
catheters.
It may be concealed happening.
Yes, ma'am.
So taking pulse, blood pressure along with vaginal bleeding is very, very important.
Absolutely,
patient
ma'am. There is
monitoring
no
has to-
underestimation of the vital monitoring. Which has to
Patient
continue.
monitoring has to go on. In
Yes,
case the patient's vitals are deteriorating, then we have to go on to, and simultaneously we have to ensure that the facility for the next step is already there in place.
Correct,
Not
ma'am.
that we wait for it and we will simultaneously arrange call for the expert and
ma'am.
also make arrangements for the OT. Blood preparation, blood products has to go on. All these things has to go on, not that we go one after the other.
So rightly said,
Yes,
ma'am. Thank you so much. That means, yeah.
If you are using normally made condom catheter and vitals you are checking, then you can mark over the
Yes, ma'am. Yes, ma'am. Yes.
if the blood is collecting,
Yeah.
it will
Then it will rise.
Yes, yes,
ma'am.
yes. Yeah, it's written in
Very
all the
well said.
guidelines, ma'am. Thank you, ma'am.
For NASG, if you have availability,
Yes, ma'am.
We will come to that.
So,
So,
just one more point
yeah.
that now that we have Chhattisgarh modification, we have
Yes,
seen. See, it's very easy to have a catheter where the drainage can also be observed. And as
Exactly,
ma'am rightly said, that we mark the height of the fundus, and these two plus the patient's monitoring.
Monitor
Pulse if
vitals.
patient is continuing to have tachycardia,
Catheter in
Yes.
situ.
and
Yeah.
urine output.
it's a
is
very small
increasing.
thing, but very important thing,
Because
catheterization.
by the time the patient has a low blood pressure, we probably already, losing the battle.
Yes, ma'am. Correct, ma'am. So this is a Pingal approach which has to be taken into consideration, which is given by your sites and endorsed by FIGO. And as ma'am said, that if we do not have the resources at our end in a small setup, when the patient converts to major PPH, she needs to temporizing measures and she should be immediately referred. And if the patient is hemodynamically stable, the balloon tamponade can be done. So next question, ma'am, what are the prerequisites for balloon tamponade? You've already discussed,
already
so
discussed.
we can just skip this question.
It was discussed that patient should be hemodynamically stable. Yes,
Stable.
Renu ma'am.
Can I
Yes,
just,
yes.
just add, if with tamponade the bleeding is not reducing, look for traumatic cause also.
Right.
Yes,
ma'am,
ma'am.
right,
Ma'am
ma'am.
had said that traumatic PPH has to be
Only after ruling
ruling out.
Yeah.
Yes,
This
ma'am.
is not so simple, there might be atonic. as
Right,
well as
right,
Yeah,
right.
both
It
are
may be a combination
yeah,
of both.
both are
yes.
mostly coexisting, ma'am. So, ma'am, what is the mechanism of action of balloon tamponade? Ma'am has
Renu
already
ma'am-
highlighted.
Renu ma'am can tell us.
But if Renu ma'am can take.
already done.
Not only tamponade, it is said that it generates uterine contractions.
Yes, ma'am.
So the next.
Yes, ma'am. So monitoring, as ma'am has said, that has to continue and investigations to be done. And the prerequisite was a hemodynamically stable patient. Balloon tamponade test, ma'am has already highlighted.
Yeah,
So
पीछे
this
जाना
patient.
हाँ,
This one. So the
This
OT was
question.
busy. The balloon tamponade test was negative. OT was busy with an ectopic pregnancy in shock, which was being operated by the residents, and surgery was in progress. The table was not there. So what would you do, Renu ma'am?
Which Renu?
Renu.
कोई भी रेनू मैम एनी
Both of them.
जो दोनों बताइए मैडम.
ठीक है, as the OT is busy and the patient is not responding to the balloon tamponade, then we have to go to the next step and she has to go in for the surgical management. But because the OT is not available, then we
So
can do
we'll go for-
we can take some action, steps. We can do the bimanual compression of the uterus, or we can do the aortic compression, or we can also, if we are in the peripheral center and we have to, then we can use the anti-shock
Anti-shock.
garment also.
Exactly. So these
And-
are described as temporizing methods by FIGO 2022. So we should remember these three temporizing methods. Next.
So as there is a balancing decision when to actually take the patient for surgical management. So now the OT gets available. Reena ma'am, so what can we do?
OT is now available, but we have to see whether the patient condition is
Patient is still hemodynamically stable. Still hemodynamically stable.
Yeah.
Yeah.
we open the we do the laparotomy and we have to put the brace suture.
Yes, ma'am.
Which
Yes.
is mostly in this case because uterus has not been opened, so it will be thinny suture as well as we can put square sutures in the lower segment.
Right, ma'am.
And simultaneously, if the tone is not coming and if you are not comfortable, then you have to go for stepwise respiration.
Excellent,
So
ma'am.
these are the compression sutures as ma'am.
Chop, then this thing is not there.
Yes, that is why we have said patient is still hemodynamically stable. Because once the patient goes into shock, only role of hysterectomy.
Then we cannot keep attempting to apply these sutures. We must definitely go ahead with the early recourse to hysterectomy.
RCG guideline says that a Billing suture laminated diagram should be there in every maternity OT. Or in other words, I can say that every obstetrician should know at least one method of compression sutures, whatever they are convinced
One
with.
more important thing is we often forget that when you have opened the abdomen, your assistant can directly now
Compress
the
it.
aorta.
Yes, ma'am.
Meanwhile, you can buy time.
This is described by ma'am, these square sutures, madam.
Yeah.
In fact, I am sharing my one experience. There was a case in which I performed a hysterectomy. I performed internal alligator ligation also. Still the vault was bleeding. I did not have photo to, because it was lost somewhere. So I put chose suture on the vaginal vault and the bleeding stopped.
Even, Dr. Shashi, even in one of my case also, like we use the Cho's cracker in the lower uterine segment and the vaginal wall, and they're supposed to be very good to, arrest
Yes,
the
yes.
hemorrhage from there. This is.
Placental bed. Yes, ma'am.
Yes, yes,
Figure
yes.
of 8. Yes, ma'am.
You could see one more after radical hysterectomy when you are
Move to
Correct,
next.
ma'am.
Move to next.
So, ma'am, the brace suture was also not working in this patient. So, Punita ma'am, now what we should
Renu
do?
ma'am.
So patient is already opened up. So what we will do is that we can do stepwise uterine revascularization can be done, unilateral and bilateral in fact, and we keep on observing and monitoring the patient, and we have to ensure that enough blood is being given. If this is also not helping, then internal iliac ligation, bilateral, both has to be done. It in fact reduces blood flow to almost 50%. So that's a very good this thing. It will reduce the blood flow.
Just read this.
Yes,
So
ma'am.
that's we can
So
do.
FIGO
and-
recommends that IL is one of the options to rapidly control PPH for the management of PPH when the medical non-surgical approach and the compression sutures, they have all been exhausted. And FIGO also recommends that all obstetricians should familiarize themselves with the internal like artery ligation and with the technique of its ligation.
So this is an important message for everyone.
So once you master this, it's a very easy and a life-saving procedure, and this should be in the armamentarium for all the obstetricians currently.
You know, when I started performing internal iliac ligation, I thought that it is a very important surgical skill to be learned by obstetrician. And to my utter surprise, now FIGO has recommended this.
So
It's good.
patient responded to internal
Just
artery ligation. and we
one
were able
point
to-
I would like to highlight.
Yes,
Like
ma'am.
for this patient, you said that she is fifth gravida with para 4, family almost complete, and if she becomes hemodynamically unstable in a patient where uterine conservation is not very important, we can go in for hysterectomy also.
Yes, ma'am. Early recourse to hysterectomy.
But
can
our
be
patient
taken.
is still here, hemodynamically stable.
Yeah. So because any operative procedure, prolonged surgery is a traumatic procedure.
Yes,
So
ma'am.
we should reduce the operative time as much as possible.
Yes,
so
ma'am.
I would at least
Tubal
recommend that.
ligation. Yes, tubal ligation.
Ma'am, tubal
Next one,
ligation, actually, if the
no,
patient
no.
is
I
hemodynamically
personally
unstable.
feel no.
Ma'am, if his
Yes, ma'am.
patient...
See,
ली नहीं है तो
the consent भी ले ली है. When see this patient is so
How she behaves later on because of
Yeah. So, ma'am,
patient is under anesthesia. We have not taken consent earlier, तो हम नहीं ligation करेंगे उसकी. Yeah.
In a situation where we are doing, obstetrical hysterectomy, neither the self-hysterectomy nor the oophorectomy or tubal ligation, any added procedure
Should not be done.
ma'am, also if the patient had given consent earlier, like it is said that it has to be taken in the antenatal period only. So had we taken the consent from the patient for ligation earlier, but suppose she landed up in cesarean, but still this is an adverse event, and it is also said that family planning procedures should not be combined
Yeah.
with any patient who is undergoing an adverse event. So we don't know what would be the course in the hospital. So later on we should explain her that patient went...
No, patient.
ma'am.
No. We will inform the patient later
Ma'am,
that
we should
we
inform the
avoided
patient's
this
relatives.
procedure
Yes, ma'am.
because each.
Our family planning officer, nodal officer says, state nodal, that they duly take into consideration what were the underlying factors.
Correct,
But it
ma'am.
is always better as clinician to avoid such.
Yes,
So
ma'am.
finally,
Because
these
we don't know
patients
what
on these patients we
family planning
performed.
death has to be reported.
Right.
So nobody wants to unnecessarily get into that.
Yes, ma'am.
So
So, Renu ma'am, if you could tell us the standard blood transfusion protocol.
So madam, the massive blood protocol, like we are nowadays giving 6 units of packed RBCs, 6 of FFP, and 6 of platelets and cryoprecipitate for the 10 units, and this is for the second round. Third round you have already, and whenever we are using massive, then we have to give the calcium gluconate also.
Yes, ma'am.
And that is 10% 10 ml IV to reverse.
So for
this.
10 ml.
rightly said, ma'am. So for students, remember 6:4:4 or 1:1:1. That's all.
Yes, ma'am. So, ma'am, we had actually prepared 4 cases, but I think we are already running short
There
of
is
time.
one secondary hemorrhage.
So, one small case of secondary
yeah.
PPH. We would like to go ahead with that.
Some other day we will discuss in details. We have very good cases.
So, this was a G5P4L4 patient who had a vaginal
It's a real
delivery.
case which I did.
Yeah, who had a vaginal delivery 10 days back, and she came to the casualty of DDU, and on examination the patient was afebrile. She had tachycardia to the tune of 118 per minute. She reported with severe bleeding per vaginum on day 10 of her delivery. Her pulse was 134, blood pressure was 110/60. She was definitely in shock, and
What is the significance of these vitals? Renu Mishra ma'am.
Renu Mishra or Renu Manchanda?
Renu Manchanda.
Renu Mishra ma'am के लिए
So whenever we have whenever the patient is bleeding, I consider obstetrical shock index, and the shock index is heart rate divided by the systolic blood pressure, and if it is more than 1, it indicates that the chances of patient requiring massive blood transfusion or surgical intervention become very high.
That's a great message. In spite of having systolic BP more than 100, she is in shock.
She is in shock.
So this is a message for the postgraduates that shock index should always be calculated, because
even if you're not calculating, what is important here is the pulse rate.
Pulse
if
rate,
a patient has
Tachycardia.
remember, don't wait for a BP to fall. So even if you're not doing a shock index, because all these things like new fancy terms come, shock index.
Where is the problem?
What?
Pulse divided by
No, ma'am, that's not the point. I'm saying everybody may not know the term shock index. What is important is tachycardia is very, very important.
Yes, ma'am. Next.
It will be more than 1 only when the pulse rate is higher than the systolic blood pressure.
So Renu Mishra ma'am, what is the cause of this PPH in this patient?
PPH on day 10.
Bleeding on day 10, and how would you manage this patient?
Secondary hemorrhage. Most commonly secondary hemorrhage occurs either due to infection or due to some retained products. So that one has to see. So I mean, since it is happening after 10 days, you would want to do an ultrasound to look for any retained products. And if there is any history suggestive that the patient could have infection like prolonged labor, preterm rupture, prolonged rupture, anything like that. Even cesarean sections tend to have higher incidence of endometritis. So in fact, I always tell my juniors, there's no need to routinely do an MRP on cesarean.
It is a very important thing, not to do routine MRP.
Just wait, there is no hurry. Unless patient is bleeding, you don't need to do MRP. Everybody is in such hurry to take out the baby, to take out the placenta. So it's not a great idea. So anyway, मैम फिर भी बहुत सारे लोग उसको निकालते हैं हाथ डाल के
निकाल देते हैं
they don't wait for the spontaneous expulsion, they will,
so it increases the risk of endometritis. So basically in such patients you need to start them on antibiotics. If there is retained products, again one word of caution, the maximum adhesions and the worst effect on fertility with Asherman's is in postpartum curettage. So if you have to do suction, be very, very careful, very gentle. You don't do a sort of curettage with a blunt and sharp curette. Very gentle suction. And of course, you do the rest of the resuscitation, blood and everything. So
nicely explained, ma'am. And for postgraduates, for suction curettage, as ma'am has said that we do not use sharp instruments. We can use a anterior vaginal wall retractor for the purpose. We are still using it, anterior vaginal wall retractor, because it is blunt and it is good for the size of the uterus. Yes.
Even suction is enough. It should be very gentle, because
in this case, I attempted a DNE, but the bleeding did not stop.
Yeah, so medical management failed, UBT failed, uterus was still atonic, and decision because she was already having 4
There
children.
is one word here written, balloon tamponade failed. And now you will see later on in next 2 slides why balloon tamponade failed. I myself could not, this was the reason.
Because the cavity was full of products of conception.
I removed this uterus.
So
we did not get ultrasound done because it was done in all hurry. In evening hours, we do not have available.
And also, ultrasound is not always, if patient is actively bleeding, ultrasound may not give you 100%.
So in this uterus, balloon tamponade cannot work.
Yeah,
so this is also a message for our residents that we should not wait for the ultrasound.
Multiple clots हैं खाली.
No,
तो balloon tamponade को फूलने की जगह ही नहीं मिली.
May not be correct if there's active
इसका
bleeding.
मेरे पास लाइव वीडियो भी है इस केस का. ये खाली क्लॉट्स हैं. मैं नहीं फेल हो गया मेडिकल मैनेजमेंट, ठीक नहीं हुआ, तो हमने सोचा बैलून टम्पोनाइट डालेंगे. बैलून टम्पोनाइट काम नहीं करा. बाद में समझ में आया कि क्यों नहीं काम कर रहा, क्योंकि इतने सारे क्लॉट्स भरे जो निकल ही नहीं रहे.
तो सक्शन नहीं किया तो वो
डिजिटल कितना जाएगा अंदर, बहुत दूर तक तो जाएगा नहीं ना. और पेशेंट शॉक में पड़ा हुआ था, तो मैंने हिस्टेरेक्टोमी करी नहीं, तो बच नहीं पाता पेशेंट. जब खोल के देखा यूट्रस का कर सेक्शन, तो ये मिला मुझे.
So point of care ultrasound.
So मतलब मैसेज इस केस से ये है कि whenever the patient is in shock, तो the role of conservative methods decreases and the role of other radical methods comes up.
So we request
Dr. Ina Yadav madam, कोई expert आपका comment madam, पूरे whole बस our panel. Yes ma'am. Nice, just like a normal uterus it was felt, normal involuting uterus. It was day 10. It was not a rupture uterus.
Ma'am,
We
products-
performed the hysterectomy. पीछे जाओ, पीछे जाइए.
Ma'am, cut section of uterus
Cut
was
section
full
है.
of clots.
पीछे जाइए. मैम मैंने hysterectomy करी इसकी सब टोटल. तो बाद में जब काटा तो ये मिला मुझे.
मैडम,
तब मुझे समझ आया कि बैलून टेम्पोलाइजर क्यों नहीं काम कर रहा. मे बी. हाँ.
plus after 10 days the infection also
पेशेंट ऑलरेडी हमें शॉक में ही मिला था.
हाँ, शॉक में है.
Shock
the
में मिला
evidence
था.
of this
तो मतलब
So the patient who is in shock and completed her family.
नेक्स्ट स्लाइड
So
निकालिए. नेक्स्ट
Yes,
इसके बाद वाली स्लाइड निकालिए. हाँ, ये देखिए हमने इसको इसमें वी हैड गिवन हर 4 PRBC 4 FFP 4 प्लेटलेट्स. तो इसमें कंजर्वेटिव मेथड का कोई रोल वैसे भी खत्म हो जाता है.
yes, ma'am. ठीक है.
नहीं वो तो हो सकता है. The only thing is कि शॉक में है तो otherwise तो this could have been suctioned out.
रीना मैडम के लिए हमने बहुत बढ़िया पैस के क्वेश्चंस रखे थे, पर मैडम आज टाइम सब लोग जा रहे हैं तो फिर कभी डिस्कस करेंगे.
So to summarize, because our the workshop was based upon the bundle approach endorsed by FIGO.
हमारा definition है
the
bundle approach.
Yeah, so the PPH drill, as we have already highlighted, it is hemostasis. Hemo is the medical management, stasis is the surgical management starting from the UBT, and we must not panic. And our take-home message is that PPH, being a serious life-threatening obstetrical problem, is the forerunner in all near miss,
Yeah, just
and
one
golden
line
hour
answer.
is pivotal. The early recognition and management is essential
Just
through
one line,
hemostasis algorithm.
So remove the word panic from your dictionary.
Yeah. And we must practice and practice these PPH drills, avoid mistakes, and we must be the 4 R's which FIGO says. There should be readiness, there should be recognition. In recognition of PPH, there should be response, and also there should be reporting and learning from all the incidents or the PPH cases which are happening, so that we can save other lives as well and learn also.
First, a lot of mistakes on the part of, doctors.
So this is PPH bundle approach.
Yes, ma'am. Yes.
So we were talking about bundle approach. So this is the PPH bundle approach. Here there are. You go on.
Yeah. So PPH bundle approach. So PPH emergency response, as ma'am has said, call for help, and it uses all the modalities of treatment within the first 2 hours.
2 घंटे में सारी चीजें यूज कर लीजिए. पेशेंट मरेगा नहीं. पेशेंट मरेगा नहीं.
Time is
most important. Within 2 hours, rather preferably 1.5 घंटे में कोशिश करिए कि सारी चीजें यूज कर लीजिए.
So the bundle.
ये नहीं कि एक जगह बैठ गए.
Yeah. So the bundle is the first response bundle and the refractory bundle.
Yes.
Because in
बहुत
smaller
important है.
hospitals,
It's
the
a very great
anesthetists are
asset.
not available always, so they should be alerted in time.
Not required, call them.
Yes. We always call them. Yes, बिल्कुल. Yes, important.
Hemodynamically unstable patient bleeding, then a senior obstetrician.
Senior obstetrician should
Yes,
be called
yes,
up.
yes.
Yes, ma'am. Yes,
In
ma'am.
our hospital, whenever hysterectomy is done, we ourselves go and do it.
Even the blood bank officials, they should be taken in loop,
Blood bank
because
must be
you
alerted,
need
very
massive blood
important.
transfusion for the
ब्लड बैंक को
compliments.
ये भी बताना जरूरी है कि पीपीएच हो गया है और ये भी बताना जरूरी है बहुत ब्लड की रिक्वायरमेंट नहीं है. दिस बोथ आर वेरी इंपॉर्टेंट.
Waste भी नहीं होना चाहिए.
Both stage of labor should be taken seriously.
Yes, ma'am.
If a patient is trickling, don't send her to the ward.
Yes, ma'am.
यस बस खत्म कर दो. थैंक यू कर दो बस लास्ट में.
यही कर
हाँ यही हो गया. इसके बाद क्या है. अच्छा हाँ ये कर.
Because I think although like Dr. Shashi is saying that internal should be learned by everyone, but when you are in the learning phase, you may take little more time finding the ligation.
Yes, ma'am.
So that at that time the life of the patient is more important, and most of the time I also go in directly for the hysterectomy.
Yeah.
Yeah. Learning stage, one should not try on an emergency.
Yeah.
Right,
Yes, ma'am.
right.
It could be tried in an elective case.
Normal cesarean section, you can open anything.
Yes, ma'am.
Yes,
Elective
yes,
case
yes,
or a
yes,
normal
yes.
cesarean.
और यदि आपको इंटरनल आलेख नहीं आते तब भी स्टेरेक्टोमी करके मरीज को बचा के आ सकते हो.
See, what is more important is when to take the decision.
Yes, ma'am. So the time management is important.
Some of my last 50 years experience, that when a cesarean in third stage of labor, if any one of the postgraduate had missed active management of third stage of labor, it was 10 points were detected from our assessment. One thing. Secondly, this fourth stage. And whenever we were taught cesarean section, this uterine
मेरी आदत है किसी भी ढंग से एडजस्ट करा
uterine art is very effective. Very effective. It was taught to us कि और sincere है सब बच जाओ.
अब इंटरप्ट करा रहे हैं.
For most of the placenta previa cases, we are doing uterine artery ligation before, removing the placenta.
Uterine artery was taught
That
Yes,
Yeah.
sir.
And even I feel uterine artery is very effective. In fact, I
Yes.
remember a patient in AIMS where we did internal iliac, उसके बाद भी bleeding बंद नहीं हुई, फिर hysterectomy करी. So internal iliac भी ऐसी full
नहीं नहीं फुल प्रूफ नहीं है, ऐसा नहीं है.
I think I like आप लोगों ने मिस किया होगा डॉक्टर महेश.
उन्होंने clearly बोला.
He said upper segment it is atonic.
Yes.
Lower segment it is.
This means traumatic.
Traumatic.
Yeah.
Secreta kind of a thing. And if it is traumatic, it is
Lower cervix.
So I think treatment for everything is different.
Yes, ma'am.
So
And this 2 hours you must remember. And
So-
tranexamic acid का journal में आ गया. 23
Yes, ma'am.
23 के BJOG के 23 वाला है बहुत.
अच्छा उसमें भी आ गया हाँ.
कहाँ साल से हम लोग
तो
selected papers is there.
ओके मैम.
Decreases the incidence means loss of blood loss decreases to less than 500 cc in normal delivery and less than
Oh, very nice.
cc in
Yes, ma'am. In all patients who are high risk of PPH.
cases.
So
Within 3 hours.
एक जो आपके 1 ग्राम है 10 मिनट में 10 मिनट.
yes मैम ओवर 10 minutes. Over 10
Over
minutes.
10 minutes, हाँ.
इससे कार्डियक अरेस्ट हो सकता है जल्दी जल्दी से. हाँ.
Slowly.
हाँ.
10 minutes
तो
you have to give it, not slower than that also.
so last part of our panel, this is obstetric hemorrhage chart. सारे हॉस्पिटल इस टाइप का एक ऑब्स्टेटिक हेमरेज चार्ट अपना अपना बना सकते हैं, यूज कर सकते हैं. एक तो ये डॉक्यूमेंटेशन के लिए इट इज़ वेरी गुड एंड एट द सेम टाइम इट इज एक्ट्स एज अ चेकलिस्ट सो वी कैन नॉट फॉरगेट एनी स्टेप. और दिस इज द पीपीएच वॉल चार्ट. ये उस पर मिलता है ग्लोम में. जो फिगो का जो एकेडमिक विंग है ग्लोम बोलते हैं उसको. उस वहाँ से मैंने ये लिया है, मेरे अपने लेबर रूम में मैंने ये लगा रखा है. इट इज़ वेरी वेरी यूजफुल, वेरी वेरी यूजफुल. रेजिडेंट्स को कुछ नहीं पता है तो वो इसको देख के पढ़ के सब कुछ कर लेते हैं. यस ये इतना बड़ा लगा रखा है मैंने. So take this opportunity to convert your nightmare into an expertise, learn every skill of managing postpartum hemorrhage, save mother, and saving mother का कितना बड़ा फायदा है, we save a family. So death due to PPH is completely preventable.
Thank you.
I request Dr. Shahada Jain ma'am to kindly felicitate the moderators.